Thanks very much for the invitation to speak. It's a great honor to speak at a session or the sessions that honor Dr. Reddy. A lot of the work that we've done at the Heart Institute, both within CT and outside of CT, is really a tribute to his leadership. So today I thought I'd catch everyone's attention, talk about cardiac CT as a potential competitive modality to perfusion imaging. These are my disclosures. So CT, is it the jack of all trades, or at least the jack of many trades? And if you look at the different things that we do within cardiology and the imaging that we perform, we try to answer, do patients have coronary artery disease? What do their arteries look like? Do they have ischemia? We look at the myocardium. We're very much interested in LV ejection fraction, but we also want to look at diastolic function. And in many cases, as you've heard earlier today, characterization of the myocardium. There's potential indications for delineating masses and thrombus. Valvular heart disease is a large component of our practice, so we want to look at valves. The pericardium, obviously, in patients with pericarditis, constriction, conduction abnormalities, patients requiring pacemakers, ICDs, etc., exercise capability in congenital heart disease. And what I'll highlight, or in red, not crossed out, are the potential information that you can delineate from CT. We don't have the ability to look at conduction disease or exercise physiology, obviously. But most pertinent to our audience today is really, coronary arteries. Do the patients have coronary artery disease? Do they have myocardial ischemia? Do they have viability when we decide about revascularization? And then as well, as I mentioned earlier, LV ejection fraction and characterization of the myocardium. So are we competing for the same population? And the obvious answer is yes, there's always competition, but competition is good. So this is a physician in Ontario, and the interesting story is Dr. Beanlands ordered a CT, not a PET, for this individual. But you can see on the left-hand side, the patient has a severe stenosis in the proximal LAD, and on the right-hand side, the corresponding angiogram, basically demonstrating that beginning many, many years ago, I think this was done maybe 15 to 18 years ago, we have the ability to image coronaries and look at anatomy. This is an example here of how fast a CT scan is. So this is what we call the flash mode. So it's a high pitch image acquisition. So basically within, the images can be acquired within 300 to 400 milliseconds. So we are faster than our current techniques of perfusion imaging. And similar to some of the slides showed earlier, the Ontario government also went back and looked at the diagnostic performance of CT. This is using older CT technology and older CT data, but showed that CT had very good sensitivity of 98% and specificity that was lower, but similar to the other modalities that are currently available to us. The one take-home message from CTs, we're very good at ruling out disease. So highlighted in green, the green curve, in patients in let's say less than high pretest probability, a negative CT almost is able to almost exclusively exclude the presence of obstructive coronary disease. So we often will use CT as a gatekeeper to rule out disease. And why is this pertinent? So this is data from the US, and interestingly enough, on a meeting with the Ontario government, the data is very similar in Ontario. The number of angiograms that are being performed in Canada and the US in elective patients, so these are stable outpatients, the vast majority, or at least half, don't have obstructive disease. So coronary angiography, or at least invasive coronary angiography, a very expensive modality, very limited access. We potentially are not using our resources appropriately. And the question that begs to be answered is, should we be using CT or other modalities to function as better gatekeepers? Now, CT has become mainstream. If you look at all the guidelines that have been published within the past 5 years, they've all advocated or bumped cardiac CT to the class 1 indication. And if the NICE guidelines, which basically originate out of the UK, state that everyone should get CT as a first-line indication. The other larger societies, the European Heart Society of Cardiology and the American College of Cardiology, advocate that they should be considered a modality that is potentially available, but in consideration, but also consider the other available modalities that we traditionally use. So what does CT do? So CT is actually, so this is data that originates from our center, and if I'm not mistaken, I believe Dr. Ruddy was the senior author on this one, where we actually looked at outcomes of CT findings. And the one thing, as you would expect, if we can actually define coronary artery disease, we should be able to identify high-risk individuals, and by identifying those high-risk individuals, their event rates are, relatively speaking, high. The novel thing is that, if you don't have any coronary atherosclerosis, your event rate is very low. And if you look at the cardiac deaths, there was one cardiac death. So the interesting story is this was not an ischemic death. This was actually a patient with cancer, cardiac cancer death. So that was, unfortunately, we didn't define, ischemic cardiac death as an outcome. Otherwise, it would have been 0. But the other thing on the graph, if you looked very closely, is atherosclerosis, and we're actually able to identify patients with coronary atherosclerosis. So here's an image of a different patient with an LAD, and if you do a short axis slice in the center picture, you'll see I don't have a pointer here necessarily, but in the center there's a round white structure, which is considered relatively normal lumen, at least in size. And then if you look to the right, that lumen is much, much smaller. That white is much, much smaller, but surrounding it is this gray, and that gray is non-calcific coronary atherosclerosis. Later studies, or more contemporary studies, have actually demonstrated our ability to characterize plaque. So when we see a rim, so that gray has a rim, and then in the center there's a little bit of a dark area, that's often lipid core. And we know that that actually is very much associated with future adverse events such as acute coronary syndrome, infarct, and death. I don't need to remind the audience that it's a spectrum of disease in terms of atherosclerosis. 50% of the patients that present with their first episode of coronary disease present with stable symptoms, and these are the individuals we typically see in the stress lab, the nuclear lab, and the CT lab. The other 50% actually present with acute infarcts, unheralded, and sudden death, so sudden cardiac death. And most of these individuals, had we done a CT beforehand, they wouldn't have had obstructive coronary disease. So basically highlights there's a population that's perhaps underdiagnosed, not a subclinical coronary atherosclerosis that potentially we can intervene upon. Now, we typically use clinical risk predictors, and in Canada we advocate the use of the Framingham risk score to identify patients who are at greatest risk of future adverse events, and we guide therapy based on these numbers. But this is a data that we published, again, probably about 15 years ago, that demonstrates that the presence of atherosclerosis is not linearly related to the Framingham risk score. Again, identifying that CT actually has some incremental prognostic and diagnostic value in identifying patients with subclinical atherosclerosis. So CT is a potential competitor, but can it be complementary? And I'll just speak very quickly on this slide that anatomy does not beget function. And we've learned this over and over again, and this is where we believe that CT and perfusion imaging actually have a role together. On the left-hand side of the screen is data from the FAME study. In red is the threshold, an FFR threshold. So above the red line, we would argue the lesions that are visualized or diagnosed anatomically are not flow limiting. Below the red line are the lesions that are considered flow limiting or hemodynamically significant. Along the x-axis, there's the different severities of stenosis, 50 to 70. 71 to 90, and then 91 to 99. And the take-home message from this is in individuals with lesions less than 70%, the vast majority are not flow limiting, where there is going to be a subgroup that will have hemodynamic significance. Between 70 to 90, so traditionally in the cath lab, anything above 70 warrants quote unquote fixing, at least based on very old literature and practice. But you'll notice that even in individuals that are have lesions between 71 and 90, there's a proportion of individuals where those lesions are potentially not flow limiting and in theory would have a negative perfusion scan. And even in individuals that have severe lesions between 91 and 99, there's a very small proportion, but a proportion of individuals where perhaps that lesion is not functionally significant. And the reason this is important is the slide on the right, or the right-hand side of the slide, that demonstrates that if we use this red line to guide therapy and revascularization strategies, that red line, functional assessment, is actually more important than anatomical assessment. Now, so how does CT come into play in terms of perfusion imaging? So on the right-hand side, I'm not certain if it'll play though. Yeah, there we go. So we can actually do something similar to PET, where we can actually do dynamic image acquisition, where we can actually infuse contrast, take a series of CT images, and basically create images on the left where you can see that there's a hypoperfused area in the inferior wall, and you can quantify this looking for areas of ischemia. Although this has been done, it hasn't been adopted into clinical practice for numerous reasons, which we can always discuss offline. Now, what has come down the pipeline is that red line that I demonstrated can actually be replicated with CT using fluid hemodynamic modeling. And this is a group, a vendor in the US that actually provides a service where you send them your CT data and they can potentially model and detect areas of ischemia. It hasn't been adopted in Canada, although it is Health Canada approved. And this is the email when I sent them. So we do some research with them, but I sent them, how much do you charge for FFRCT? Because we had a patient who actually had a borderline lesion. And basically says the cost of FFRCT is $1,100 US, $1,400 Canadian, and the patient has to pay out of pocket. And you can imagine within the Canadian system, $1,400 can buy you a lot, right? You could probably buy you a PET and maybe half a SPECT. So, many of us have actually, in these individuals, foregone FFRCT and moved on to functional imaging at our functional imaging for the such patients. Now, FFRCT is not perfect, right? So yes, it's a potential competitor, but we would acknowledge, and this is a meta-analysis that was previously performed, and actually there was a second meta-analysis that showed the same thing, that the gray area, or FFRCT, becomes less accurate at around 0.8. And if you remember from the slide, the cutoff, the threshold for intervention is 0.8. So FFRCT is very accurate at either end of the spectrum, but where you need it the most, it's the least accurate. So although it's been adopted worldwide, there are some limitations to using FFRCT. So this is just another case of mine, a patient of mine with a severe lesion in the PIV, which you can actually see on the left-hand side of the screen, a short axis slice of the severe lesion, the hypoattenuating, low attenuating plaque, the lipid core in the center with that little almost black circle surrounded by the gray rim, and then the corresponding area of what we would consider normal lumen. But we can identify large plaque, we can't identify small plaque, and we miss a lot of plaque. And this is really a slide to highlight the limitations of the spatial resolution of CT. So CT has a spatial resolution of approximately 300 to 400 microns. The data, histopathological data, has looked at plaque and looked at different sizes of plaque. And, the size of plaque, you can imagine as it gets smaller, we become less diagnostically accurate. And partial volume is a big issue. So we have issues with partial volume in perfusion imaging, apical thinning, the basal aspects of the myocardium. We have the same thing with CT, and you can imagine as we're looking at smaller and smaller structures, the edges become even more blurred, hence limiting our diagnostic ability. And this is actually accentuated when we actually have very small lumens. So if you think about coronary artery disease, a 4 millimeter lumen, which we would consider large and sizable, we can image easily. But when you have a severe stenosis, you're now talking about a lumen that's less than a millimeter, which in theory is represented by 2 or 3 pixels in diameter. So again, partial volume has a huge impact on our diagnostic accuracy. This is real world data that originated from our center and others that basically demonstrated that there is variability in reading ability and accuracy. So just to highlight, CT is very sensitive and it's supposed to be it has good specificity and it's supposed to have very high negative predictive value. Having said that, if you look at the very bottom right corner, you'll see that the negative predictive value will vary from centers to center, somewhere between 40% and 95%. So again, acknowledging the potential limitation in centers who perhaps don't do higher volumes. This is data that again has come from our center looking at CT and its ability to look at viability imaging and scar imaging similar to MR. And if you compare let's say the polar map in the center, which is the CT, and the polar map of the corresponding FDG images for the same patient, you can see that the reds, the yellows, the blues, and the blacks line up relatively well. So CT has the potential ability to look at scar imaging similar to MR, but again, much more difficult than MR. And even though we've worked on it, it's not something we do routinely. This is just a sample case where if you look at the red arrows, on the right-hand side is the MR with late GAD enhancements. On CT with maybe an eye of faith, you can see something similar. Lastly, cardiac function. So we gate our CTs similar to perfusion imaging, and we have the ability to put the gated images together and actually look at wall motion and estimate LV ejection fraction, and as well RV ejection fraction had there been contrast in the RV. So who do we blame for cardiac CT in Ottawa? Well, it's interesting. Dr. Higginson and Dr. Ruddy were the chiefs when we implemented CT. So part of the blame is, I think, Dr. Ruddy. But having said that, he's been a great colleague, mentor, and friend. The most important thing that allowed us to push forward with CT is that Dr. Ruddy, acknowledged and supported new technologies, even when it may have been detrimental to nuclear cardiology. So he pushed patient care over, interest. And we all recognize that he's always been a supporter. I remember we had installed the first dedicated cardiac CT, and the expectation was to publish immediately. And so Dr. Ruddy and I had this discussion about strategies, and there's two options. Yeah, we can publish immediately, but low impact, or we wait it out and we make huge strides within CT and get the recognition that the Heart Institute deserved. And he kind of supported the second or the latter thought, and we were able to kind of at least move CT forward both locally and nationally and internationally. So, the fact that he had the long game in mind is something that I think we valued very much. And to his credit, now CT, at least in Ottawa, is internationally renowned. Thanks very much.